have the privilege today to introduce our speaker, Dan Gottlieb. Dan, I've known him for quite a long time. He's been his education took him through University of Pennsylvania School of Medicine, Harvard College, Boston University School of Medicine, Boston University School of Public Health. He's done quite a bit over the past several years. He's currently associate professor in the School in Medicine at Harvard Medical School. He's on the faculty of the program of sleep medicine epidemiology in the division of sleep medicine at Brigham and Women's. He's also the director of the sleep medicine program at the Boston VA Medical Center, where he's also been involved over the years and a key person in our own sleep medicine fellowship training program. Dan's done quite a bit over the years in a variety of areas related to sleep medicine and epidemiology. He's currently involved with moving forward quite a bit, but currently he's involved in studying metrics for sleep apnea, cardiovascular risk. And I told him when I was reviewing some of this material of all the things he's done over the years, and I told him that he's done too much and it's time to slow down. But he said he's thinking about it. Anyway, so and in fact, today he's going to talk about sleep apnea, cardiovascular risk, and I'd like to turn it over to Dan Gottlieb. Thank you, Dan.
All right, thank you, Sandy. So I am going to talk about sleep apnea and cardiovascular disease, which is what I've focused on for the last several decades, and in particular try to make some sense of the negative randomized clinical trials that have been published over the last few years. These are my disclosures. I don't think any of them are particularly relevant to the talk I'm giving today. So it's been known for over 4 decades that there's an association between obstructive sleep apnea and cardiovascular disease. And a number of clinic-based observational studies over the years have found that in patients with untreated obstructive sleep apnea, they have an increased risk of heart attack, stroke, and death. And this has been seen in both men and women over a sustained period of time. Similar findings have also come from population-based epidemiology studies, including the Wisconsin Sleep Cohort Study and the Sleep Heart Health Study, which have found that after adjusting for multiple cardiovascular risk factors, that sleep apnea is associated with an increased incidence of hypertension, with increased risk of a myocardial infarction and a heart failure, as well as with increased risk of stroke and death. And I think one of the nicest graphics comes from a paper that Niresh Punjabi published from the Sleep Heart Health Study, showing that after adjusting for these multiple factors that are risk factors for mortality, that as severity of sleep apnea as measured by the AHI increases, there's increased mortality. Now, in addition to these observational findings, there's good biological plausibility for an association of sleep apnea with cardiovascular disease. I'm not going to spend a whole hour talking about what's on this slide. You can go to Malcolm Cowley's paper to read more, but basically it focuses on intermittent hypoxia and reoxygenation, which is a potent stimulus to systemic inflammation, as well as to increase sympathetic nervous system activation. And then there are animal and human physiologic models that also support an association of sleep apnea with cardiovascular disease. This is Elliot Philipson's remarkable dog model from back in the 90s, where they gave dogs sleep apnea at night, and over a period of as little as 1 to 2 months, they developed fairly profound daytime hypertension, whereas dogs whose sleep was fragmented with an acoustic stimulus did not. And human physiologic studies, decades ago, Rick Fletcher showed that the high levels of sympathetic activity both at night and during the day in patients with obstructive sleep apnea, and that fell substantially with tracheotomy, which was the only really effective treatment available at that time. More recently, Renaud Temissier and colleagues in Grenoble showed that 14 days of intermittent hypoxia during sleep raises blood pressure in healthy young adults. Mariam Louis and Naresh Punjabi at Hopkins showed that 8 hours of intermittent hypoxia, even during wakefulness, resulted in impaired insulin sensitivity in healthy young adults. Moreover, beyond the data from observational epi studies and the biology of disease and these physiologic models, there's evidence from what we call quasi-experimental studies, in which what we see is that patients with untreated severe obstructive sleep apnea, this is from Jose Marin's study from Zaragoza, Spain, the ones with untreated moderate to severe sleep apnea had substantially increased risk of both fatal and non-fatal cardiovascular disease, while patients with treated obstructive sleep apnea had a risk that was no different from people with snoring without sleep apnea. And similar findings have come from multiple clinic-based observational studies where there's a high risk of cardiovascular, cerebrovascular morbidity and mortality in untreated sleep apnea, but that risk appears to be completely eliminated in patients who are treated for sleep apnea. So it seems like pretty much a slam dunk for supporting a causal association of sleep apnea with cardiovascular disease. The observational cohort data from both clinic and population-based studies, good biological plausibility for an association, physiologic models in both animals and humans supporting this association, and these quasi-experimental clinical studies suggesting that treatment of sleep apnea reduces cardiovascular risk. Well, if only it were this simple. Because the randomized clinical trials, which we generally think of as the highest level of evidence for clinical decision making, these trials tell a very different story. There have been, a number of studies have shown that the treatment of CPAP does lower blood pressure in patients with hypertension, and this is tends to be greater at night than during the day. The effect is larger in patients with resistant hypertension than in patients without, who have well-controlled hypertension. The effect is modest, 2, 3, 4 millimeters of mercury, but it's not trivial, not necessarily unimportant. However, the trials that look at whether treating obstructive sleep apnea with CPAP will reduce the risk of major adverse cardiovascular and cerebrovascular events have basically resulted in null findings. So the two figures here are from the two largest such studies, the Sleep Apnea Vascular Endpoints, or SAVE trial, which found that that CPAP was associated with there's a 10% greater risk in patients using CPAP compared to those randomized to usual care, and the ESOC study, which found an 11% again, non-significant reduction in apparent reduction in risk in patients using CPAP. Recently, there was published an individual participant data meta-analysis of the 3 main cardiovascular secondary prevention trials using CPAP, the RCADSA, SAVE, and ESOC studies. And again, they showed absolutely no reduction in risk of new or recurrent cardiovascular events with CPAP, with an overall hazard ratio of 1.01 favoring usual care. Now, these data have received different interpretations from different quarters. The Agency for Healthcare Research and Quality concluded that ignoring the evidence that CPAP reduces sleepiness in patients with sleep apnea, concluded that randomized clinical trials did not provide evidence that CPAP prescription affects long-term clinically important outcomes. In contrast, the sleep community, by and large, has concluded there must be something wrong with these studies. And so what I'm going to do over the next half hour is to talk about some potential reasons why these clinical trials may have failed to identify a benefit of CPAP treatment. One is the possibility that sleep apnea may, in fact, not cause cardiovascular disease. Another is that it's been suggested is that low CPAP adherence in these trials may have prevented them from being able to detect the benefit of therapy. It's also possible that the cardiovascular risk from sleep apnea may already be adequately controlled by usual cardiovascular care. It's been suggested that inappropriate patient selection for these clinical trials may have led to the null findings. And one that you may well not have heard suggested before is that CPAP may have unanticipated harms that could counteract the expected benefits of treating obstructive sleep apnea. So I'll go through those one at a time. So is it really plausible that sleep apnea might not cause cardiovascular disease? I hope my punctuation here makes it clear that I don't think that's the case. Well, what about all those observational studies that suggest that it is? And I want to have an open mind here to this possibility that it might not cause cardiovascular disease. There's certainly risks of residual confounding in observational studies. And one obvious potential unmeasured confounder is visceral adiposity. We usually use BMI to adjust for adiposity, but BMI only explains about 25% of the variance in visceral adiposity, which appears to be more important both for sleep apnea and for cardiovascular disease. And then we tend not to measure activity and diet very well in these studies, and there may be other both sleep and other comorbidities that don't get factored in. So there certainly is the possibility for confounding the observational studies. What about the quasi-experimental studies, where patients who are adherent to CPAP have much lower risk than people who are not adherent to CPAP? And I think that it's important here to be aware of something called the healthy adherer effect. It's been well known in cardiovascular literature for decades. It seems to me that it's not very well recognized within the sleep community. This is a study published back in 2006, looking at a number of cardiovascular metabolic treatment trials dating back to the 1970s. And what they showed was that in the placebo arms of these studies, that good adherence to placebo was associated with a 45% lower mortality risk than poor adherence to placebo. So this is a very large effect. One of the graphics I think that best demonstrates this is from the candesartan heart failure study. This shows in the hot colors patients who were randomized to candesartan, in the cold colors patients who were randomized to placebo, and they've divided them up by those who were highly adherent to therapy, that is, they took more than 80% of their doses, versus those who took fewer than 80% of their doses. And what you can see is that in both the adherent and the non-adherent groups, candesartan was associated with lower mortality, with an overall about 10% risk reduction. On the other hand, simply being adherent, whether it was to placebo or to candesartan, was associated with 35% lower risk. So typically the effect of the health of simply being adherent to therapy, regardless of whether the therapy is effective or not, dwarfs the effect of active therapy. And as a result, studies comparing adherent to non-adherent patients are inherently flawed. And I will come back to this because I think it's very important for our field to be aware of. Now, it's been suggested, not without reason, that low CPAP adherence in these clinical trials may have prevented the ability to detect a significant effective therapy. And if you look at the three secondary prevention trials, where COTS, SAVE, and ESOC, the overall median adherence was only 3 hours per night, which is, I will have to say, somewhat low. Now, we tend to think of, we have as our sort of arbitrary threshold for adherence using CPAP for at least 4 hours a night, 5 nights a week. That is to say, at least 20 hours a week. Well, a median adherence of 3 hours a night, that's about 20 hours a week. And so, although it's not great adherence, I might have expected, if CPAP were beneficial in this group, to see at least a trend in the direction favoring CPAP. But again, absolutely no evidence of a CPAP benefit in these three trials. Now, because of concern that low adherence may have been a problem, they also did an as treated analysis where they compared the roughly 40% of patients who used CPAP for 4 or more hours a night to the patients who used it less. And what they found was that, lo and behold, the patients who were adherent to CPAP had about a 30% lower risk of major adverse cardiovascular and cerebrovascular events than the people who were poorly adherent to CPAP. And the conclusion in the key points blurb there in JAMA was that patients with established cardiovascular disease and OSA who use CPAP 4 more hours a day had a significantly lower risk of major adverse cardiovascular and cerebrovascular events than those who use CPAP less than 4 hours a day. But what I think it's important to point out is that this effect of being adherent to CPAP was actually slightly less than the effect of adherence to placebo in multiple prior cardiovascular trials and trials of the TORCH trial of inhaled therapy for COPD, in the Women's Health Initiative trials of hormone replacement therapy, and in prostate cancer prevention therapy for men. So there's not really much reason to think that this effect was a result of CPAP, but rather it was an effect of being an adherent individual. And the models, while they did very fancy marginal structural Cox models to adjust for potential confounders, the models can only adjust for variables that are included in the model. And unless those variables are associated with the things that underlie the healthy adherer effect, they're not going to adjust for that effect. And we know from prior studies that sociodemographic factors, adherence to other medications, lifestyle factors, including smoking, physical activity, these things explain very little of the effect of being adherent to placebo in prior studies of pharmacologic therapy. And until we understand what those factors are that underlie the CPAP-related healthy adherer effect, analyses that compare CPAP adherent to CPAP non-adherent patients should be ignored, flat out ignored. I think they're of dubious value and they're likely highly misleading. And the conclusion they will lead to is we simply need to push people harder to use their CPAP, even though we don't have evidence that it may be beneficial for them. So I think that low CPAP here probably does not explain the lack of CPAP effect in these randomized clinical trials. Now, I think there is a reason to think that the sleep apnea-related cardiovascular risk, the CPAP may cause excess cardiovascular risk, but it may be adequately treated by usual cardiac care. So in these secondary prevention trials, patients are already being actively managed to reduce cardiovascular risk. Most of them are on antihypertensives, beta blockers, lipid lowering agents, glucose control if they're diabetic, antiplatelet therapy, not to mention anatomic therapies such as coronary bypass procedures, or angioplasty, as well as being recommended diet and exercise interventions. And so this may well be treating the downstream effects of sleep apnea. We may not need CPAP to do that. And just as an example of how that might work, this is a study that Jean-Louis Pepin and colleagues did where they took patients with newly diagnosed hypertension and obstructive sleep apnea, and they randomized them to treatment with either CPAP or valsartan. Now, CPAP did significantly reduce blood pressure over the course of a 24-hour monitoring, but valsartan did a much better job, right? So if you wanted to control hypertension in someone with sleep apnea, you're much better off using valsartan than CPAP. And so it may be that the medications these patients are taking are already taking care of the sleep apnea-related cardiovascular risk. We don't know that, but I think it's a possibility that needs to be considered. Another area that's gotten a fair amount of attention is whether the correct patients were included in these clinical trials, because participants have generally been selected based on having established cardiovascular disease, being screened for obstructive sleep apnea, and then those with an elevated AHI being enrolled in the study. And in general, patients who are sleepy have been excluded from these trials because it's been felt to be not ethical to leave someone untreated when we know that their sleepiness can be treated with CPAP, leaving them untreated for a period of several years. And it's a reasonable question whether patients with an elevated AHI but without sleepiness, which is the majority of patients with an elevated AHI in the population, whether they really have a disease or whether it's merely an incidental polysomnographic finding. And several studies suggest that it's really the sleepy patients with an elevated AHI who are at greatest cardiovascular risk. This is a study done somewhere in the suburbs of Philadelphia at elderly independent living facilities where they screened these individuals, not patients. And what they found was that those who had both an elevated AHI and excessive sleepiness had increased mortality, but those with either sleepiness alone or an elevated AHI alone had no worse outcome than patients with neither. Similarly, in a study from the Mayo Clinic, in patients following a myocardial infarction, what they found was that it was the patients with an elevated AHI and excessive sleepiness or an increased risk for recurrent major adverse cardiovascular and cerebrovascular events, whereas patients who had an elevated AHI but were not excessively sleepy did not appear to have increased risk compared to those without sleep apnea. And in the sleep heart health study, what we saw was that compared to people with an AHI less than 5, shown in black, it was only the patients with an AHI greater than 15 who were also excessively sleepy who had a significantly increased risk of incident cardiovascular disease, about a 2-fold increased risk. Whereas patients with an AHI greater than 15 who were either minimally symptomatic or only moderately sleepy or had disrupted sleep did not have a significantly increased cardiovascular risk. So exclusion of sleepy patients from clinical trials may well have identified patients with a physiologic abnormality, but not a disease that was associated with increased cardiovascular risk. Now, that said, even these intermediate groups appear to have somewhat increased risk, even if it was not statistically significant. And I think we can't necessarily ignore people who are not excessively sleepy. But I think what's important is, how do we identify the group that's likely to benefit, if there is one, from CPAP therapy? One thing we could do would be to include sleepy patients in these trials, but I think there are both ethical and practical challenges to enrolling sleepy patients and potentially randomizing them to no CPAP for a period of years, although it's not impossible. But I think that a better approach would be to try to utilize the wealth of data that we collect with sleep testing, and rather than collapsing that into a single, very limited metric, the Apnea-Hypopnea Index, to try and use the wealth of data that we collect to identify patients at greater risk. And there's a lot of work going on in this area right now. I'll mention a little bit of it, but it includes looking at measures of hypoxemia, maybe respiratory event duration or clustering of events during the night, or the stage in which events occur, or the physiologic response to these respiratory events, such as changes in heart rate or blood pressure or changes in the EEG, may be things that could better help us identify patients who are likely to benefit from treatment. Of course, it's clear to everyone, I'm sure, that you can respiratory events can have very different degrees of desaturation. These show 2 different patients here, one with a whole lot of respiratory events and very little desaturation. They'd have a very high AHI. Another patient with many fewer events, but very long events with much greater desaturation. They have a much lower AHI, but it's not clear which of those is the more severe illness. A Finnish group a decade ago demonstrated that if you adjust the AHI for the degree of desaturation, that adjusted measure more closely associates with both all-cause and cardiovascular mortality than the AHI alone. More recently, this is one of Eleazar Barzin's papers. He's looked at hypoxia in a somewhat different way, looking at the average desaturation associated with the respiratory events, and has shown in both the Sleep Heart Health study and the Mr. Oss study that with increasing, he's called this measure the hypoxic burden, with increasing level of hypoxic burden, there is increased mortality, and that is even after adjusting for our conventional metrics such as the Apnea-Hypopnea Index, the low saturation, or the total sleep time below 90% saturated. So maybe using metrics like that could help us to identify patients at greater risk. I think looking at what may be even more useful is looking at the physiologic response to respiratory events, which differ greatly among individuals. This shows 2 individuals in the top panel, and these 2 individuals have similar AHI, similar degrees of desaturation with events, but one individual has very little heart rate response to those events, whereas the other has a very robust increase in heart rate with events. And one thing that Ali has shown is that these are data from the Sleep Heart Health study, the patients who have a large increase in heart rate with their respiratory events have a higher risk of both non-fatal and fatal cardiovascular disease events over time. Now, The people who have very little heart rate response also had a somewhat increased risk, and that's something that, in the interest of time, I won't get into here, but our suspicion is that these people have advanced heart disease to begin with, and for that reason don't respond very well to a sympathetic stimulus. To show the potential usefulness of a measure like this, I went back to the Ricazza study, which is one of these randomized clinical trials of non-sleepy patients with following a revascularization procedure, were screened for sleep apnea, and these are non-sleepy patients. And overall, there was no significant improvement, no significant reduction in cardiovascular risk with CPAP. But in the group that had a high heart rate response to events, which is the group that in other cohorts was seen to be at greatest cardiovascular risk from sleep apnea, it appeared that CPAP did reduce the risk of recurrent events. So this clearly needs to be replicated, but it's sort of a proof of concept for how these physiologic measures might help to identify the patients at risk and the patients who might be usefully enrolled in clinical trials. In a very recently published study, it was shown that higher loop gain, a measure of respiratory instability that can be called an endotype of obstructive sleep apnea, the higher loop gain appeared to predict greater blood pressure reduction with CPAP in looking in a secondary analysis of data from the heartbeat study. So again, something that needs to be replicated, but more proof of concept that these physiologic measures may help us to better identify patients. So I think that understanding these individual physiologic, as well as demographic, genetic, and other personal factors that predict increased sleep apnea-related cardiovascular risk, and even more importantly, predict the response to therapy with CPAP may help us to design better clinical trials. It may identify a target population that's more likely to respond to therapy, whether or not they're symptomatic. And it may also clinically help us to identify among the very large group of asymptomatic patients with an elevated AHI who may derive benefit from treatment. Now, I also want to talk about something that I think has not gotten much attention, but it's a concern that we've stumbled onto in research over the last couple of years. We know that a lot of people don't like CPAP, right? Many tell you that their sleep is worse with it than without it. They find they have trouble exhaling. It makes them anxious. We know that CPAP decreases venous return to the heart, which in the short run may be beneficial for patients with decompensated heart failure, although it potentially may contribute to deleterious effects down the road, as was suggested for the SERVE-HF study. But I never really gave much thought to whether CPAP might have other cardiovascular harm until doing a study where we were looking at a number of markers that we thought would be associated with. We're doing a study to look at whether sleep apnea may increase risk of interstitial lung disease. We looked at a number of biomarkers associated both with sleep apnea and with interstitial lung disease, and to see whether those would improve with sleep apnea treatment. I'm not going to go into details of that cohort, but one of our findings was that serum angiopoietin-2, which we thought would go down with therapy, actually went up significantly. And we thought, well, this is probably a spurious finding. We looked in another small sample of patients that Sonia Jellick had enrolled in another trial. These were health screen individuals, so their overall angiopoietin levels were lower, and the effect was even more dramatic. So it was, well, maybe there's something to this. Sonia went on to look at it in a larger cohort of health screen individuals, and once again found this roughly a 500 picogram per mil increase in angiopoietin-2 with CPAP therapy. So why do we care about angiopoietin-2? Well, angiopoietin-2 it's contained in Weber-Piloty bodies. in endothelial cells along with von Willebrand factor. It's released in response to endothelial cell injury, but also in response to intermittent hypoxia. And for that reason, it's increased in people who have obstructive sleep apnea. And it has both angiogenic and pro-inflammatory properties. And in population studies, higher levels, such as the Framingham Heart Study, higher levels of angiopoietin-2 are predictive of cardiovascular mortality. And in reading about this, what I learned was that in endothelial cell vascular ex vivo models, stretching endothelial cells by as little as 20% leads to a rapid increase in angiopoietin-2 secretion. And thinking about CPAP, we did not think about too much, but it was shown about 40 years ago that about a 10 centimeter of water increase in positive airway pressure leads to an increase in functional residual capacity of the lung by about 1 liter, which is roughly twice the tidal volume. So it's a pretty substantial increase in lung volume with CPAP. It's part of the reason that people don't tolerate it very well. And the question that raised for us is this, not only making people uncomfortable, but is it leading to the development of a pro-inflammatory state? And so we decided we wanted to look at this in a clinical trial paradigm. We went back to the Ricazza study, where Yüksel Pecker very graciously allowed us to work with data and together with him on data and samples that they had collected in the Ricazza study, which again was a randomized trial of CPAP versus usual care in patients following coronary revascularization. And in addition to angiopoietin-2, which is associated with both endothelial inflammation as well as angiogenesis, we looked at E-selectin, another marker of endothelial inflammation. We looked at RAGE, the receptor of advanced glycation end products, which is a marker of lung epithelial inflammation. And we also looked at VEGF-A, which is a marker of angiogenesis. And there's an interesting relationship between angiopoietin-2 and VEGF-A, which is that in the presence of high levels of VEGF, angiopoietin-2 tends to be angiogenic, whereas in low levels of VEGF, angiopoietin-2 tends to be inflammatory. So what do we find? Well, as we had seen in the prior CPAP treatment trials, I'll have to back up slightly. These were patients, remember, who are recently post-coronary revascularization. So we know that their vascular inflammatory marker levels are going to be high at baseline, and they tend to come down over time. And what we saw in the Ricazza trial was that over 12 months, there was a large reduction in the level of angiopoietin in the usual care group. But in the patients randomized to CPAP, angiopoietin levels remained elevated, actually went up some. E-selectin went down in both groups, a little bit more than the usual care group, although not significantly so. There was a larger drop in RAGE in the usual care group than the CPAP group, although this was a very variable measure, in part because it doesn't get very well out from the lungs into the blood, and that was not a significant difference. But VEGF levels fell significantly with CPAP. Now, that's a finding that's been seen, reported several times in the past, and it's been thought, oh, well, that's a good thing, that VEGF is going down with treatment. But in fact, with elevated angiopoietin and reduced levels of VEGF, that may actually lead to a more vascular inflammatory milieu than you would have with elevated VEGF levels. And so the model that we propose is that obstructive sleep apnea via intermittent hypoxia does lead to endothelial dysfunction, release of angiopoietin-2, and that's likely to increase cardiovascular risk. Now, when you treat with CPAP, you block that intermittent hypoxia, and so you block that pathway to cardiovascular risk. But we think that alveolar distension may lead to increases in the release of angiopoietin-2, possibly increasing the epithelial inflammation as well, and simultaneously reduces VEGF, leading to a vascular inflammatory milieu that may increase cardiovascular risk. So, coming back to the potential reasons I suggested and that others have suggested as potentially leading to a null finding of these randomized clinical trials of CPAP therapy, I think it's probably not true that sleep apnea doesn't cause cardiovascular disease. I think that the evidence for an increased risk, at least in some people, and it may be that it's in people with more severe disease, which reflects most of the physiologic studies, as opposed to the people identified in the population, most of whom have very mild disease. But certainly, at least in some group of patients with sleep apnea, it's almost certainly a cause of cardiovascular disease. I don't think that low CPAP adherence was the main issue. Certainly, the better adherence, the more likely you are to see an effective therapy, but I don't think that can explain the null findings of the Ricazza-SAVE and ESOC studies. I do think that the adequate control of cardiovascular risk by any hypertensives and so forth in these secondary prevention trials may really impede the ability to see additional further risk from CPAP. And maybe that's a reason why we should be thinking about doing primary prevention trials, although they tend to be much more costly than secondary prevention trials because of the low rate of events. Although, if those physiologic markers allow us to select a particularly high-risk group, that may be a feasible approach. I think almost certainly a selection of patients who were at low risk for recurrent cardiovascular events contributed to the null findings of those published randomized clinical trials. But finally, I think that we need to do more research to better understand this finding. I do think we should have an open mind to the possibility that CPAP may have unanticipated harms, and that it's something that we certainly need to look into more. It may be that treating with lower pressures of CPAP that may not get rid of every last respiratory event might still be beneficial without those harms. So our future research needs, I think we need to validate the novel physiologic markers to help us better target patients for clinical trials. That we need to explore the implications of these effects of CPAP on endothelial inflammatory markers to determine whether it's clinically meaningful or not. I certainly think it's a little bit early to be making any changes to clinical practice based on what we've seen. And finally, I think we should consider whether cardiovascular risk reduction strategies other than treating sleep apnea may be an approach that we should be taking. Clinically, I think not everyone with an elevated AHI needs CPAP. I believe, I've been saying it for 20 years, I believe it more now than I did then. We need to focus on patient symptoms and not on the AHI. And for people who have an elevated AHI and no minimal symptoms, we should be making a shared decision with those patients based on the limitations of our knowledge and probably focus on multiple risk factor reduction. And I'm just going to acknowledge my collaborators in the studies I mentioned, looking at angiopoietin too. And I'll stop there and be happy to take any questions.
Dan, do you think more precise apnea treatment would be beneficial?
By a more precise apnea treatment, tell me what you mean.
Endotype-driven treatment. So it's not just CPAP, but it's targeting loop gain, arousal threshold, persistent desats, whatever, not just use of CPAP for so many hours.
Well, I think it's possible. I mean, obviously, the beauty of CPAP is that it can control sleep apnea in almost everyone. But it's poorly tolerated. I think that I don't know that, I think that endotype-driven treatment is very likely to help us identify treatments that are better tolerated by individual patients. Whether or not they would lead to better outcomes other than the symptomatic outcomes, I think it's a reasonable question. It's one that we don't yet know. let's see. I can look here at the
Thanks,
chat.
Dan. Maybe I can help moderate
Yeah,
the discussion. So
Right.
Dr. Heckman is asking a question about, whether CPAP adherence is a potential explanation or not. And his question/statement is, an issue with assuming that the CPAP adherent group effects is all healthy adherer effect is that it assumes that CPAP applied was successful and that only patients' internal motivation dictated non-compliance. It is not possible that the non-adherent group is enriched for endotypes of sleep apnea that were not effectively treated with generic CPAP provided. So I think this kind of gets a little bit also at what Robert was saying, is that maybe the people who are dropping off are the ones who are not able to reap the symptomatic benefit or to have their sleep apnea adequately treated.
Well, I'll say two things. One is, if you look at that, at the meta-analysis of the 3 clinical trials, the 2 lines for recurrent events perfectly overlap, right? If there was a group that actually benefited from CPAP therapy and had lower risk, then it's a mathematical certainty that the group that was not adherent to CPAP did worse than patients who were not treated at all. And I can't see that there's an explanation for that other than a healthy adherer effect, that you've separated out adherent from non-adherent patients. And the things that lead to people to be non-adherent to medications, I think probably even more so to CPAP, are not the things that are readily available in a medical record. They're things like, the other factors in their life that compete with taking care of their health as a priority. And there will be actually a good pro-con debate coming out in sleep in the near future addressing this question of whether a comparison of adherent to non-adherent patients. But I think that if you believe that the adherent patients are doing well because they're adhering, then you have to believe the non-adherent patients are doing poorly because they're not adhering. And that doesn't make very much sense to me. I think that we're cherry picking a group that does better for those reasons of adherence, not that the CPAP itself is doing something. I think it's incumbent upon the people who believe that that is the case to demonstrate that the healthy adherer effect is not biasing that finding.
Okay, thanks. And then there is a question from Clar, and first he wants to congratulate you on a fantastic talk. And Clara was also saying that it's also worth emphasizing that the post-hoc CPAP analysis regarding interactions with hypoxic burden and delta heart rate are not linked to CPAP adherence. And these analyses seem more compelling because they are not subject to healthy adherence.
Yeah, well,
what are your comments on that?
Yeah, so I think that's true, and so I think that those things may be very profitable in identifying who it is that's going to benefit from therapy. Most of these have been done in one cohort, right? As a post hoc analysis, and they had there was some biological rationale for thinking this might be beneficial. And I think what we're waiting for, and we'll hopefully see over the next couple of years, is a replication of these and other trials that have been done, as well as perhaps some demonstrations in clinical trials with those people that there is at least an effect on intermediate outcomes. Obviously, the long-term outcome trials will take longer, but I think those are really critical to designing the right clinical trials that will tell us whether CPAP treatment is beneficial or not beneficial.
Yeah, great, thank you. And then Dr. Francois Roux is asking a question: do sleepy patients have worse endothelial function compared to non-sleepy patients?
That's a very good question, and someone may know the answer to that, and if they do, they should speak up. I do not I do not know the answer to that.
Yeah, I mean, I think there's sort of circuitous answer to that is that, obese patients versus non-obese patients certainly have worse endothelial function, and those who are obese tend to be more sleepy. But I'm not sure if anyone's actually looked at the endothelial function directly.
I'm going to put that on my list.
Accounting for obesity. I guess, Dan, I wanted to ask you another question. I mean, you put together some provoking work recently about CPAP maybe having unintended harmful consequences. And so, it's sort of curious. I mean, these are good hypotheses. I mean, how do you reconcile that with the data that has shown that, for example, CPAP improves endothelial function with FMD and it improves MESNA. And so those mechanistic studies that have been done in the past, would you mind sort of commenting on that? And if it's hard to reconcile, how might we experimentally going forward try to address those questions?
Yeah, I think it is hard to say. I think that I say that there's a mixed literature on the effects of CPAP on endothelial function. Although I agree that the bulk of the evidence suggests that, at least looking at things like flow-mediated dilatation, you see an improvement with CPAP therapy. Certainly, that has not been uniformly found. But I think that there are a few things that we would like to do to further evaluate this. One would be to look at what happens to markers of endothelial inflammation with CPAP compared to a non-CPAP therapy, or CPAP at usual pressures versus lower pressure CPAP. I think that we will, that studies that look more directly at the endothelium, some of the studies that, such as the studies that Sinogelic and others done looking at vascular endothelium before and after treatment, focusing specifically on these, on these markers may be useful. And there are different, obviously the endothelium is complicated. The vessels are a complicated organ, and there are multiple different measures of inflammation. And so I think there's a lot more that we have to learn about this relationship. And that's why I said I don't think that these data are, at this point, are suitable for clinical, they're not clinically actionable at this point. But it was a, but the level of increase in angiopoietin-2 seen with CPAP, or the level of sustained elevation in the Ricazza study, are of a magnitude that in population studies are associated with a 10 or 15% increased mortality. So that's not trivial, because I think it would be unrealistic to think that CPAP is going to have more than that much of a reduction in mortality, given that that's what we can achieve with almost any known effective pharmacologic therapy. So I think it's important for us to think about and to study more. But I think it's complicated, and we may find that, it goes up, but it doesn't matter. We'll see.
Yeah. All right. Thanks. And then Dr. Buddha, you have a question? Go ahead and unmute yourself.
Yes. Thank you, Dan, for this wonderful lecture, like usual.
Thank you.
So one is, again, the question which was asked before. I was wondering, what's the etiology of the relation between sleepiness and CAD? We published some data from Apples, which showed that people with increased sleepiness, even with good adherence to CPAP, 1/3 of the patients still had significant residual sleepiness. So could it be that in some people, CPAP alone is not enough, even if it's bringing the AHI down significantly? And conversely, people who were not adherent to CPAP, in those people, increased mortality, could it be that CPAP is causing increased sleep fragmentation in some people, and that's why they're not adherent? Of course, we see people who've been on CPAP for 2 years, 3 years, still using it 20, 30, 40% of the times, still complaining that their sleep is much worse when they use CPAP.
So I think I'll mention, to the second point, I think Magda Yunus recently published a study showing that based on certain EEG parameters prior to treatment, you can predict who it is that's going to sleep worse with CPAP than without it. And yes, I think that that it does disrupt sleep in some people, and that may have negative consequences even beyond symptoms. To the former question, I will go back to one of the first papers I published in sleep apnea at the beginning of the Sleep Heart Health Study, which was looking at the relation of the apnea-hypopnea index to excessive sleepiness in the population, and using the Epworth Sleepiness Scale with all its warts, and using a threshold of 11 to indicate excessive sleepiness. What we saw was that with increasing severity of the AHI, there was increased prevalence of excessive sleepiness, which didn't quite get up to 50% among people with an AHI greater than 30. So most of the people, even with severe sleep apnea, weren't sleepy by that metric. But conversely, among the people who had an AHI less than 5, 20% of them had excessive sleepiness. So we know that even among people with obstructive sleep apnea, a lot of them are probably sleepy for reasons that are other than sleep apnea. And we're not going to treat that with CPAP. So even people who are very adherent and their sleepiness doesn't get better, some of them, it may be that they have irreversible sequelae of longstanding severe sleep apnea. I think that's probably a small minority. I think more often they have sleepiness for other reasons, some of which we can identify. Most of them don't sleep enough, just like everybody else. Some that we can identify, what the relationship of that, there are studies showing that sleepiness per se is associated with poor, long-term outcomes. So I think it is an important area to focus on, even independent of sleep apnea.
Thanks, Dan. If there are other questions, please ask them. You can do it in the chat or raise your hand. I'm happy to give you the mic, virtual mic, so to speak. I guess, Dan, while we have you here, you've done a lot of work in sort of observational studies, and you've done clinical trials. And one of the things that you mentioned during your talk today is, well, maybe we should be focusing on primary prevention. And so, imagine you have limitless resources and, you have the biomarkers that you need to. How would you design the next primary prevention trial in sleep apnea?
Well, I think what I would do would be to use a questionnaire to screen generally to screen a population free of cardiovascular disease, but probably in middle or later middle-aged, who and then screen them with a questionnaire to identify risk for sleep apnea, and then actually test them to identify those who have markers suggesting particularly high risk, whether that's delta heart rate or one of the endotypes, and then do a study very much like Ricadza Save or ASOC, randomizing them to CPAP or usual care, with the proviso that I would probably try to expend the resources to improve adherence, so that we can put to bed the idea that poor adherence is the reason for not finding an effect. The last thing we want is another negative trial in people who use their CPAP for only 3 hours a night, because it will never be clear what the answer is. Now, right. I think that I think it is worth considering the ethics of doing a trial in patients who are fully informed, who are sleepy, who are willing to be randomized. And it may be that a design like that would include some other measure to treat the symptoms, such as an alerting agent, alerting medication, to make so that so that in both cases you're treating the symptom, and now you'll have a chance of seeing whether treating the other physiologic effects of sleep apnea, most notably the intermittent asphyxia, prevents the reduces the cardiovascular risk.
Thank you, Dan. And so there's a couple of other questions that came up, and this is a great talk and great discussion. So thanks to you for the talk and for everyone for contributing to the questions. So first question is, in the Sleep Heart Health study, I'm guessing that's with respect to cardiovascular risk, was the study analysis controlling for beta blocker use? And another question, if you can keep two in mind, is when we look at cardiovascular disease outcomes, does it matter if we look at prediction with 3% AHI, 4% AHI, or AHI related arousals?
So I'll answer the second question first. And that is, if you're looking at AHI 3% or AHI 4%, or even AHI 3% in arousal, slightly less so, the correlation between them is so high that it really doesn't matter which one you use. However, we can't keep using the same threshold for abnormality for AHI 4% as we do for AHI 3% or arousal, since we know that the latter has about 3 times as great at the lower end of severity. It's just ridiculous. So no, I don't think it really matters too much which one you use, so long as you use a threshold that reasonably identifies moderate to severe disease. As far as the former question, we did have the data on medication use. Honestly, I have to go back to papers to see to what extent it was incorporated in those risk models, because it's so long ago that they were written. If we didn't take it into account, then it probably, to some extent, minimized the effect estimates, I would guess, but I don't know for sure off the top of my head.
Right. Well, thank you so much, Dan, and thank you, Dr. Auerbach, for a wonderful session, and appreciate you all attending. And we will see you in 1 month's time. Take care, everyone.
Thank you for the invitation.